Welcome, peers. Okay, let's get right into this explainer. Today, we're zeroing in on some seriously granular clinical decision boundaries. We're stepping into the shoes of an expert clinical consultant to break down a few highly complex urologic and nephrologic presentations. And listen, we're completely bypassing the standard test prep filler here. We're going straight for the subtle physiological variables that actually dictate high-stakes patient management.
So here is our docket for today. We're hitting nephrolithiasis decompression thresholds, post-obstructive retention dynamics, genitourinary neoplasia surgical branch points, and we'll wrap up with clinical reconciliation and fraught variants.
All right, Module 1. Let's dive into the mechanical and biochemical realities of nephrolithiasis.
Now, what's absolutely crucial here is how we have to instantly map stone chemistry, because that directly dictates our imaging and our initial management. Take calcium oxalate stones. They account for about 80% of presentations, right? They're radio-opaque, envelope-shaped, and they absolutely thrive in hypercalciuric environments. But then contrast that with uric acid stones. Those are radiolucent, rhomboid-shaped, and they precipitate out in highly acidic urine. You literally have to know what you're hunting for before you even order the scan.
And this brings us to the real game changer, the emergency pivot. We have to constantly evaluate baseline versus emergency status. Sure, stable stones under 6 millimeters are mostly going to clear conservatively. Give them some hydration, maybe some alpha blockers, and they're fine. But an obstructing stone that's complicated by a UTI or a fever, that demands an immediate pivot. You have to bypass standard stone removal entirely and proceed straight to urgent surgical decompression. We're talking a ureteral stent or a percutaneous nephrostomy.
Let's actually test this branch point right now. Picture this. You have a patient presenting with a 6 millimeter stone, a temp of 101.8 Fahrenheit, and hypotension. With urosepsis clearly looming, what's your move? Do you proceed with shockwave lithotripsy, or do you go for urgent decompression? Why is delaying for definitive stone analysis a critical and potentially fatal error here?
Well, this perfectly illustrates our first fraught variance. The answer is immediate decompression. Attempting lithotripsy on an infected, obstructed kidney is a catastrophic mistake. It's like throwing gasoline on a fire. You also run the risk of diagnostic variance if you confuse those radiolucent uric acid stones for blood clots or transitional cell tumors on non-contrast imaging. The key takeaway: the physiology absolutely must dictate the mechanics.
Okay, moving right along to Module 2. Let's see how all this builds into mechanical retention and its physiologic aftermath. We have to be able to rapidly distinguish the etiology of acute urinary retention. Contrast the mechanical obstruction of benign prostatic hyperplasia, which hits that central periurethral zone, causing progressive difficulty voiding, against neurological failure pathways. I mean things like a neurogenic bladder, driven by diabetic neuropathy, paralysis, or even anticholinergic triggers. Selecting the correct decompressive sequence relies completely on nailing down that underlying pathology.
But regardless of the cause, the acute decompressive sequence is incredibly strict. First up, you decompress via Foley or a suprapubic catheter, but the work doesn't stop once the catheter's in. Second, you must aggressively monitor for physiologic post-obstructive diuresis. And third, you have to replace that massive urine output with hypotonic fluid to prevent rapid volume depletion, all while keeping a hawk's eye on those electrolytes.
So here is your choice architecture. The acute retention is relieved, but suddenly the patient's urine output spikes to an outrageous 800 milliliters per hour. What do? Do you mandate oral hydration, intravenous half-normal saline titration, or just sit back and purely monitor? You have to differentiate the self-limiting physiologic elimination of retained solute from a severe pathologic salt-wasting syndrome or nephrogenic diabetes insipidus.
The only correct approach here is active half-normal saline titration. Our Module 2 clinical variance isolates a massive danger, misinterpreting this post-obstructive polyuria as simple fluid overload. If you just sit back and monitor, your patient is going to crash into profound volume depletion. You have to actively titrate hypotonic fluids based on live, changing serum electrolyte trends. Shifting gears now, let's explore Module 3, diving into the surgical branch points of genitourinary malignancies. Let's look at how these malignancies actually present on the floor. Renal cell carcinoma classically shows up with that triad of flank pain, hematuria,
and a palpable mass. But pay incredibly close attention to this vital structural vascular exception, an undecompressing left-sided varicocele that stays engorged even when the patient is lying supine. This is a massive red flag signaling left renal vein invasion blocking testicular vein drainage. Bladder carcinoma, on the flip side, presents as painless, gross hematuria, usually in older patients with a heavy history of smoking or industrial dye exposure.
For bladder carcinoma, the diagnostic pathway is rigid. Non-negotiable. Once a high-risk patient comes in with painless, gross hematuria, you might do an initial screen with urine cytology, sure. But your mandatory next step is the gold standard, a diagnostic cystoscopy with transurethral resection of the bladder tumor.
This visual brilliantly illustrates the pathology we're hunting. On one hand, a direct cystoscopic view reveals a macroscopic transitional cell tumor just growing right there on the bladder wall. And then the microscopic histology backs it up completely. Papillary growth lined by transitional epithelium. This right here is exactly why direct visualization is an absolute must.
So put yourself in this scenario. You're faced with unexplained microscopic hematuria and a perfectly normal renal ultrasound in a high-risk older smoker. How do you navigate this choice variance? Do you elect repeated imaging, try a round of empiric antibiotics, or jump straight to diagnostic cystoscopy?
The fatal clinical variance here is letting that normal renal ultrasound give you a false sense of security. You must mandate a cystoscopy. Dismissing painless hematuria in this demographic as just a generic UTI or assuming a clear ultrasound rules out lower tract transitional cell carcinoma, that is a massive pitfall. Don't fall for it.
All right, let's pull all of this together in our final module on clinical reconciliation, where overlapping systemic parameters make our decision-making incredibly dense.
Look at how subtle shifts in a basic urinalysis can completely alter your entire diagnostic trajectory. A pH greater than 7? That points straight toward urease-producing organisms like Proteus. A specific gravity over 1.010 indicates hypovolemia. The presence of RBC casts practically screams glomerulonephritis, while finding pigmented, granular, or muddy brown casts definitively points you to acute tubular necrosis following an ischemic insult. These aren't just lab values, they are clinical roadmaps.
Let's evaluate a truly complex, multi-system presentation. You have a 65-year-old male smoker with known BPH. He comes in with acute left flank pain, gross hematuria, and a brand new left varicocele. How do you systematically weigh these competing priorities when the symptoms of urolithiasis perfectly overlap with a concurrent, ominous structural anomaly?
This is the true test of an expert clinical consultant, cutting through the noise. Sure, he has BPH. Yes, the flank pain and hematuria sound exactly like a stone, but isolating that singular low-frequency variable, that new undecompressing left varicocele, reveals occult renal cell carcinoma with renal vein invasion. Recognizing that one tiny detail instantly forces a complete pivot in your management pathway, pulling you away from routine stone protocols and directly toward oncologic surgical staging.
As you encounter these complex, multi-layered presentations in your practice, ask yourself, are you merely reacting to the loudest baseline symptoms, or are you actively identifying the subtle, easily missed variables that truly dictate the boundaries of definitive patient care? Keep looking for the pivot. Thanks so much for joining me on this explainer, and I'll catch you on the next deep dive.